Assalamu alaikum. My name is Dr. Syed Mashud Ahmad, and I am a consultant of medicine at Thyroid Institute. My talk today is part of online series called Knowledge for Life. It is for Waqf doctors who are working in Africa, and this is this whole series is organized by Humanity First. So the topic is type 2 diabetes mellitus. Objective of my presentation is to understand the pathophysiology and risk factor for type 2 diabetes, to understand recent guidelines and management of type 2 diabetes, and to understand a low-carb diet and its effectiveness in type 2 diabetes. The precursor to type 2 diabetes is insulin resistance, and that's a terminology which will come repeatedly in my talk. Insulin resistance can broadly be defined as a subnormal biological response to normal insulin concentration. The major causes of insulin resistance is listed here, and by far more common causes in the third part, which is known as multifactorial etiology of insulin resistance, and that include hypertension, metabolic syndrome. In fact, metabolic syndrome is nowadays called insulin resistance, and this part, actually, these are multifactorial etiology contain majority or include majority of our patients. Pathogenesis, how type 2 diabetes is developed. I mentioned insulin resistance, and if you look at the causes which are shown on the slide, the most striking, there are various, I would say there are various factors which can influence and cause diabetes mellitus. It is a complex interaction among many genes, environmental factors, which are different among different population and individual. The most striking environmental factor in most patients who develop type 2 diabetes are increased weight gain and decreased physical activity. So it's no brainer. If you want to reverse or control your diabetes, you have to do certain diet and you have to increase your physical activity. The mechanism by which obesity induces insulin resistance is poorly understood. Some research shows inflammation as a cause or a common mediator which result in obesity and which in turn causes type 2 diabetes. So this is an illustrated form of illustrated slide which shows that there is increased blood glucose and which result into increased carbohydrate intake, increased hepatic glucose production, decreased insulin secretion. Of course, if you keep on burdening your pancreas, which produces insulin, it results into decreased production of insulin secretion and decreased peripheral glucose uptake. This decreased peripheral glucose uptake, I would like to explain that this is actually insulin resistance. What happens that basically I feel the carbohydrates are main culprit. If you keep on feeding your body carbohydrate, at the cellular level, the cells are going to say enough is enough. I'm going to stop the excess of glucose. I don't need that much of glucose in me. So they will down-regulate insulin receptors. Of course, insulin, to be effective, have to attach to the receptor, and after attachment to receptor, glucose moves into the cell. So when there is down-regulation of receptor, basically there is a lot of glucose in the bloodstream, and in that case, pancreas has a natural response, increases the production of insulin, and the cells then they respond by the same way. I mean, they will keep on. It's a spiral cycle. The cells respond by then further down regulating the receptors, and so on and so forth. So at one point, there's a lot of insulin and there's a lot of sugar in the bloodstream, and then the result is type 2 diabetes. Sign and symptoms. As a physician, we are taught these sign and symptoms, and everybody know polyuria, polydipsia, and polyphagia. Blurred vision, lower extremity paresthesis, and yeast infection. Diagnostic criteria by American Diabetic Association include fasting blood sugar of equal to or more than 126 milligram per deciliter. In millimole, it equals around 7 millimole per liter. A 2-hour plasma glucose level of 200 milligram or higher during a 75 gram oral glucose tolerant test. A random plasma glucose of 200 or more in patient with classic symptoms of hyperglycemia or hyperglycemic crisis. Whether a hemoglobin A1C level of 6.5 or higher should be a primary diagnostic criteria. Still, it's a debate going on, but I personally use a hemoglobin A1C level of more than 6.5 as a diagnostic tool. Indication for diabetic screening in asymptomatic adults include following: sustained blood pressure more than 135/80. Automatically, American Diabetic Association says that we should do the diabetic workup, diagnostic diabetic workup, as mentioned earlier. Overweight and one or more other risk factor for diabetes, which include first degree relative with diabetes, blood pressure more than 140/90, and HDL less than 35 milligram per deciliter, or triglyceride more than 250 milligram per deciliter. ADA recommends screening at the age of 45 years in the absence of above criteria. Management. Goal of treatment are as follows. Goal of treatment is we want to minimize the long-standing effects of blood sugar, or actually diabetes, type 2 diabetes, on microvascular, macrovascular, and metabolic and neurological, in metabolic and neurological aspect. Recommendation for the treatment of type 2 diabetes mellitus from the European and European Association of the Study of Diabetes and American Diabetic Association place the patient condition, desires, ability, and tolerance at the center of the decision making. But what they are essentially saying here, we should, as a physician, we should individualize the treatment plan for each patient. And management contain these 7 key points: individualized glycemic target and glucose lowering therapies, diet, exercise, and education as the foundation of the treatment program, use of metformin as the optimal first-line drug unless contraindicated. After metformin, the use of 1 to 2 additional oral or injectable agents with a goal of minimizing adverse effect if possible. Ultimate insulin therapy alone or with other agents if needed to maintain blood glucose control. Where possible, all treatment decision should involve the patient with a focus on patient preference, needs, and values. A major focus on comprehensive cardiovascular risk reduction. So everybody knows long-standing diabetes causes cardiovascular events, and by cardiovascular events I mean acute MIs and cerebrovascular accident. 213 ADA guidelines. Patient on intensive insulin regimen perform SMBG at least before meals. It just simply SMBG means checking your blood sugar at home before meals and snacks, as well as occasionally after meals at bedtime, before exercise and before critical tasks like driving. When hypoglycemia is suspected, and after treating hypoglycemia until normoglycemia is achieved. Patient using less frequent insulin injections or in non-insulin therapies use SMBG results to adjust to food and intake, activity, or medication to such specific treatment goals. Clinician must not only educate these individuals on how to interpret their SMBG data, but they should also reevaluate the ongoing need for the frequency of SMBG at each routine visit. Approach to prevention of diabetic complication include following: hemoglobin A1C every 3 to 6 months, yearly dilated eye exam, annual microalbumin checks, foot examination at each visit, blood pressure 130/80 or lower in diabetic to lower the risk of diabetic nephropathy, statin therapy to reduce low density lipoprotein cholesterol. So far we have concluded the management and diagnostic criteria and pathophysiology, and now as ADA, which is American Diabetic Association, as well as European Diabetic Association, they both recommend dietary modification and lifestyle changes. Something which I have found is effective in some of my patients is a low carb diet, and in certain patients, if they stick to this diet, it actually just like a miracle has happened, their diabetes is sometime reversed. So the next topic will be like starting low carb diet with diabetes mellitus. As you can understand, the low carb diet is not a treatment only for diabetes but also for the weight loss. So when any patient is going to be started on this low carb diet, they have to stop all the drugs except metformin, which is commonly called glucophage. And if they are on insulin, they have to reduce their insulin by 30 to 50%. because by restricting carbs, there is a chance that the patient may have low level of blood sugar, which is called hypoglycemia. So the medication I mentioned earlier, all the medication except metformin is safe. And in certain instances, GLP-1 GLP-1 agonists like Victoza or DPP-4 inhibitor like Januvia, they can also be continued on low carb diet. SGLT2 inhibitors should be stopped. So just briefly introducing low carb diet, you have to reduce drastically the carb intake. If you don't reduce your carb intake, it will not work. So the basis of this diet is, if you reduce carb intake, as a result, there won't be as much insulin response, and you will be able to reverse that insulin resistance slowly with the passage of time. So you are allowed to eat, depending on how much carb restriction you're going to do, anywhere from less than 20 gram carb per day to approximately 100 gram carb per day. So just to put in perspective, a single apple has about 25 gram of carb. So obviously, initially when you're trying to control your blood sugar, fruits are not the part of the dietary plan. So this chart shows that number of carbs in 15 number of carb present in these food, which equals approximately 15 grams of carbohydrate. So, and everybody can individualize restriction of carb according to his or her tolerance level, I would say. Often we have diabetes and hypertension present simultaneously. So when you are restricting carbs, there is also tendency the blood pressure is going to go down. It's good, but word of caution here is, if somebody is on hypertensive medication, and those medication needs to be reduced or ultimately stopped if the blood pressure keep on going down, which is good. I mean, you are controlling your diabetes with the same diet, and then you are controlling your blood pressure with the same diet. This is all for today, and I'm thankful for this forum, which is called Knowledge for Life, to providing me this opportunity. Jazakallah.